Good evening, everyone. Thank you very much for attending our meeting today. We appreciate you taking the time at the start of your weekend to be with us. Today, we are privileged to have a group of very prominent clinicians in the field of anesthesia in the Middle East. And I am honored and privileged to be co-chairing this meeting with my colleague, Dr. Kamel Ben Tabak. A little bit of housekeeping to start with. Please, recording is not allowed, and as well as screenshot and photography. Please make use of the Ask the Questions button on your screen. So if you have questions, you can send them as we go ahead, and I'll be going through them. And at the end of every part of the presentation, we'll have an experts panel to discuss these questions. So make use of it, please. I would like to introduce myself. My name is Ali Razmi Ibrahim. I'm a consultant anesthesiologist at the American Hospital in Dubai. I'm a former chief of department. I'm currently the president of medical staff. I would like to pass the microphone to my colleagues, Dr. Kamel Ben Tabak, to introduce himself as my co-chairman. Dr. Kamel, please go ahead.
Thank you, Professor Ali Rasmi Ibrahim, and welcome to all our colleagues in the regional MEA. First, I would like to warmly thank MSD for associating me as a surgeon in this regional meeting. I am Professor Kamel Ben Tabak, the head of Oncological Surgery and Liver Transplantation Department at Pierre and Marie Curie Center in Algiers. I'm also the president of the Algerian Society of Surgery. As you know, surgeon and anesthetist is today an inseparable couple in the medical surgical care of patients. It begins pre-operatively with surgical and anesthesia consultation, intraoperatively during surgery with good curization for surgery in good condition, and post-operatively to avoid complication, especially pulmonary complication and post-operative pain. And thank you. Professor Rasmi?
Thank you very much, Prof. Kamel Ben Tabak. I can't agree more. I think medicine has come a long way over the last few years, but the most important advancement in medicine is this close collaboration between surgeons and anesthetists to improve the quality of care. I mean, Enhanced Recovery Program is one of the best example of that collaboration, and definitely the old enemies are the friends of today, and that's very important, for medicine and patient care. Today, I would like to really reiterate what Prof. Kamel said, that we thank MSD for being very supportive to continuous medical education in the field of anesthesia. I would like to thank all the prominent speakers today for putting a beautiful agenda and very important agenda together for our audience, and I would like to thank the audience as well. Now, our agenda it's going to consist of two parts. The first part will focus on neuromuscular blockade and its use in anesthesia, and I will be chairing this part of the meeting. And the second part will be focused on the effect of the COVID pandemics on medicine in general and the field of anesthesia and the Enhanced Recovery Program. Our first speaker will be Professor Yunus Aisawi. Professor Yunus Aisawi is a professor of anesthesia and critical care. He is the head of surgical ICU at the Avicenna Military Hospital. I hope I pronounced the name right, Prof. Yunus. And he is, thank you very much. And he's currently the chairman of the scientific committee at the Moroccan Society of Anesthesiologists. And he's an author of a peer-reviewed articles in the field of anesthesia. Prof. Yunus, the screen is yours and the stage is yours. Please go ahead with your presentation.
Good evening, everybody. Thank you, Professor Rasmi Ibrahim, for your nice introduction. And thanks for the MSD teams for the efforts and time in organizing this webinar. So I'm going to talk about postoperative pulmonary complications, their definition, incidence, and the association with residual block. Those are my disclosures. So PPCs are one of the most common postoperative complications. Their incidence range between 9 to 40%, dependent on the definition used and the surgical context. They have a major negative impact on surgical outcome by increasing morbidity and mortality, leading to prolonged hospital stays and increasing healthcare costs. Their pathogenesis depends on multiple factors related to patient status, surgical procedure, and of course, anesthetic management. And one of the most avoidable factors in anesthesia is residual neuromuscular block. So I will start with the actual definitions of PPCs. Then we will move towards speaking about PPCs, incidents and consequences of PPCs. We will review risk factors and pathophysiology of PPCs, and in particular, the link with residual neuromuscular block. And finally, we will review some important data about residual block and PPCs. So what's the PPC definitions? PPCs are a composite outcome including different adverse respiratory effects with different pathophysiological mechanisms. Could be infectious like pneumonia, could be thrombotic or cardiovascular events. It could be some thromboembolic or cardiogenic event like cardiogenic pulmonary edema or pulmonary embolism. This adverse effect could also be barotraumatic like pneumothorax or exacerbation of a pre-existing lung disease. And it could be also the most severe form of complication, namely acute respiratory failure. So clearly there is a need of a robust and consensual definition of PPCs. In 2015, European Joint Task Force defined the PPCs as a composite outcome including respiratory infection, respiratory failure, pleural effusion, atelectasis, pneumothorax, bronchospasm, and aspiration pneumonitis. But we still we feel that we are mixing different diagnoses with different mechanisms. That's why in 2018, the literature after reviewing the literature about PPCs and a 3 Delphi process, including experts in the field, they agreed that PPCs should have the same pathophysiological mechanism, including pulmonary collapse and airway contamination. So the recommended definition of PPCs are atelectasis on CT scan or chest radiography, pneumonia according to CDC criteria, postoperative acute respiratory failure, including ERDS, and pulmonary aspiration when there is a clinical history plus radiological evidence. And moreover, this consensus conference defined also the severity of PPCs, and therefore they excluded other diagnoses that are not sharing the same biological mechanism. What is the incidence of PPCs? In the last few years, there are 4 major studies which investigated the incidence of PPCs: ARISCAT study, Periscope, Las Vegas, and Popular. In the ARISCAT study, all these studies, they adopted the European definitions. In the ARISCAT study, the PPC incidence was 5%, and you can see the higher mortality observed, about 20% observed in patients which have PPCs. In the Periscope, it was 8%, and in the Las Vegas, it was 10% despite the excluded cardiothoracic surgery. The most recent one, Popular study, found an incidence of 7%. And the incidence of PPCs varies between surgical procedure with the much higher incidence in cardiothoracic surgeries than peripheral surgeries. In the Las Vegas study, they found that transplant surgery and aortic surgery have a much higher incidence than peripheral vascular surgery or upper abdominal surgery. And also, the emergency surgery is associated with an increased incidence of PPCs, and this is a slide from the Las Vegas study which showed a odds ratio of 3. What are the consequences of this complication on surgical outcome? This is a UK database study plus projection from Nepokodiev, which shows that if the perioperative period was a disease, it would be the third leading cause of death after ischemic heart disease and stroke. And of course, PPCs are one of the greatest contributor to this death, as it is shown in this large US database study of surgical patients with 2 million surgical US patients, which showed that pulmonary complications were 5 times more common than cardiac complications. The higher mortality rate was due to cardiac complications followed by PPCs. In this study by Fernandez, in the high-risk patients, non-cardiothoracic surgery, they found that patients had at least one PPC in 33%, and namely the most common complications were atelectasis and the need for postoperative oxygen. But what is interesting in this study, that even mild complications like atelectasis, pleural effusion were associated with a greater risk of ICU admission and mortality. This is a review by the team of Kane, and they show there is a huge variability in mortality due to PPCs, up to 48% in some contexts, like cardiac surgery. But we can say that 1 patient in 5 with PPCs will die in the postoperative period. They also found that there is a mean increase in PPC-related postoperative length of stay by about 8 days. The cost of surgery is also increased, and in the same review, they find that the cost increased 2 to 12-fold by PPCs, making PPCs one of the most expensive of major complications. But the question is, who gets postoperative pulmonary complications? And we have to talk about risk factors for developing this complication. These are patient-related factors, surgical factors, and also anesthesia management. And this is a nice review by Miskovic, published in the BJ in 2017, which listed the patient-related factor. Most of them are more non-modifiable. Patients with high comorbidity have the high risk of having PPCs, but there are some modifiable factors like smoking cessation and COPD preoperative optimization. As we discussed earlier, some surgical procedures carries a high risk of PPCs, but we can ask our surgeons to perform less invasive surgeries like laparoscopic surgeries and to remove quickly nasogastric tube. In anesthesia management, we have the most avoidable factor by adopting protective mechanical ventilation, by using regional anesthesia or combining regional anesthesia like epidurals with general anesthesia, by avoiding residual neuromuscular block. That's why now it is strongly recommended to use a prediction score to predict postoperative complications, and the most used score is the ARISCAT score. It has been validated. It has a good good ability to predict postoperative complication, and it was externally validated in European multicentric cohort. What is the pathophysiology of these complications? The perioperative period is an optimal period for PPCs to develop. In fact, anesthesia is going to reduce functional residual capacity and lead to atelectasis. It could depress the respiratory drive. Mechanical ventilation could lead to ventilated-induced lung injury, and surgery is going to damage respiratory muscle and to restrict ventilation in the postoperative period. And as you can see, residual neuromuscular blockade are implicated at different levels of the respiratory system. What are the effects of residual block on the respiratory system? There is, I think everyone knows the definition of residual block. There is a lot of data about the effects of residual block. This is a volunteer study which with the volunteers subjected to residual paralysis with a TOF ratio of 0.7 with using either atacurium, poncheronium, and vecuronium, and they found that there is a decrease by about 30% in the hypoxic ventilatory response, which is a physiological response who protects us from hypoxemia. And it has been shown in animal models that this is due to the depression of the nicotine-induced chemoreceptor located in the carotid body. And this experiment has recently been replicated by the team of Bruins. They showed that there is a 40% decrease in the hypoxic ventilatory response. But what is more worrying in this study is that they found that even after antagonizing the paralysant effects of these drugs, the hypoxic ventilatory response did not return to normal, to baseline values. What's the effect on upper airway? You can see on the left, the upper airway dilator muscles, they are maintaining airway patency by counteracting the negative pressure induced by the respiratory pump during inspiration. And you see the effect of residual paralysis on the right on the screen and airway collapse due to these drugs. And it has been proven in multiple studies. This is also a volunteer studies in healthy patients submitted to partial paralysis. They assessed the upper airway volume and diameters using MRI, but also the genioglossus activity, which is the most important muscle in upper airway dilators. They found that there is a significant decrease of upper airway volume and diameter leading to airway collapse, and this is probably due to the decreased activity of the genioglossus muscle. This is a study done by the same team. They gave healthy volunteers, contrast liquid, and they studied the pharyngeal and upper esophageal function in partially paralyzed volunteers. And what they found is that there is a 5 times increased risk of misdirected swallowing, leading to penetration of the larynx, as you can see in the image, but also an impairment of pharyngeal coordination and a significant decrease in upper esophageal sphincter tone. This is the last physiologic study. These volunteers were subjected to negative airway pressure, but as you can see at the left, there is an increased activity of the genioglossus muscle, which maintain airway patency. But when the volunteers are submitted to partial paralysis, there is a decrease in the genioglossus activity and airway flow limitation. And last, this is a real-life study. In the postoperative period, Kumar compared more than 100 patients with and without residual block. With block are the blue bars, and we can see that there is a significant decrease in both peak expiratory flow and vital capacity with about 20% in patients with residual block. And there is a very nice slide summarizing all the effects of residual block. Residual block will impair ventilatory drive, impair respiratory muscle function, impair ability to protect airway during swallowing, and this could lead to atelectasis, upper airway obstruction, and impaired ability to cough and clear secretion. And we are going to see these patients in the PICU with hypercarbia and hypoxia, and they are going to inhale with aspiration pneumonia, and a few days later they are going to have pneumonia and maybe the need for reintubation. So there is many data showing this effect and their pathophysiological effect on airway and on the respiratory drive. But what about real life studies? Most of the studies are registry and retrospective studies. I will start with this study by McLean, published in 2015. They found, including more than 50,000 patients, they found a dose-dependent association between intermediate acting neuromuscular blocking agent and PPCs. As you can see, that the higher are the dose received, the higher the rate of PPCs. And in the next slide, you can see the odds ratio of having PPCs according to the dose of neuromuscular blocking administered. This is a study published 1 year later by Catherine Bulka in anesthesiology. It's a retrospective study of more than 1,400 patients in the Vanderbilt University Hospital. They compared two groups, matched groups with which received the neuromuscular blocking drug and group without this drug. And also they compared patients reversed versus no reversed. They found an increase, a 2-time increase in pneumonia, in patients who receive neuromuscular blocking agents, and also an increase in more than 2-fold of PPCs in patients not reversed. 1 year later, this is a study which have the same methodology. They compared patients reversed versus not reversed, the patients receiving neuromuscular block versus no neuromuscular block administered, and they found similar results. But what is original in this study is that also they found that in patients who were not reversed, there was a marginal increase in mortality. And finally, this is a systematic review of 58 observational studies. They have two goals: to investigate the incidence of residual block and the outcome associated with the residual block. And as you can see, the yellow in the table, the yellow are the patients with the residual, and in green, the patient without residual neuromuscular block. You can see first that the residual block is very frequent, up to 90% in some sites, but also patients with residual block had higher incidence of acute respiratory events and hypoxemia. I could not finish this lecture without talking about the popular study. It's a European multicentric study which included more than 22,000 patients with the goal of investigating the relationship between muscle relaxants and PPCs. And they found that, without any surprise, patients which receive neuromuscular blocking agents has 2-time increase in the risk of having PPCs. But what was shocking in this study is that the use of neuromuscular monitoring and the use of reversal agents were associated with an increased risk of PPCs. But when we dig, and this result could have a negative message on anesthesiologists, but if we dig on the results, we can find that in this study, only 40% of patients received quantitative neuromuscular monitoring, mainly acceleromyography, but also 30% of patients were extubated with the residual block. And what contradicted the result of this study is that a post-hoc analysis of this study found that a TOF ratio of 0.95 resulted in a 30% reduction of postoperative pulmonary complication when we compare it with a TOF ratio of 0.9. So there is
Thank you, very kind.
more and more data showing that there is strong relationship between residual neuromuscular block and PPCs. And to conclude, we can actually define PPCs by diagnosis that share the same mechanism, namely collapse and airway contamination. The definition includes pneumonia, atelectasis, aspiration, and acute respiratory failure. Residual block impairs respiratory muscle control and upper airway integrity. Residual neuromuscular block is an avoidable anesthetic factor, and any bundles for PPCs prevention should include neuromuscular monitoring and adequate reversal. And this is my last slide. If I can share with you the bundles for PPC prevention adopted by the Moroccan Society of Anesthesia and Analgesia. sorry, it's in French. In the preoperative period, we recommend to use the ARISCAT score to improve the respiratory function. In the perioperative period, it is advised to prefer regional anesthesia or to combine with the general anesthesia, to prefer non-invasive procedure, to use quantitative monitoring and avoid residual block, and of course, protective ventilation, and in the postoperative patient period to put the patient in our ERAS pathway. Thank you very much for your attention.
Thank you very much, Prof. Yunus, for this very informative and excellent speech. I appreciate it. Our next speaker is Professor Mohammed Abdul Latif. Professor Mohammed Abdul Latif is a professor of anesthesiology and surgical intensive care at the Faculty of Medicine at Cairo University. He is a member of the European Society of Anesthesiologists. He has more than 40 international publications in peer review journals in the subject of anesthesia. He's a former editor of the Egyptian Journal of Anesthesia and a former associate editor of the British Journal of Anesthesia. Prof. Mohammed, thank you very much for joining us, and the stage is yours.
Thank you very much, Mr. Chairman. Thanks for MSD for giving me the opportunity to contribute to this prestigious meeting. My topic is about optimal neuromuscular monitoring and reversal in real practice, and it will be two parts, theory and clinical application by a case discussion. I would like to have two disclosures. I'm expert speaker to MSD only, and the contents of this lecture are all mine, and I'm responsible for every word that will be mentioned in this lecture. As I told you earlier, it will be a theory followed by a practical application by demonstrating a clinical scenario. The objective of my lecture is very easy, very simple, and it is the objective of every anesthesiologist to provide balanced, effective, and safe anesthesia. Balanced anesthesia, as you know, is a triad: hypnosis or unconsciousness, analgesia, and a degree of muscle relaxation or immobility as required. To ensure safety and effectiveness, you don't have much choice. According to Anesthesia Patient Safety Foundation, you need to monitor. You can monitor hypnosis by bispectral index. It is an expensive machine and it has some pitfalls. Analgesia, for the time being, is difficult to monitor. The easiest and most reliable part to be monitored of the triad is neuromuscular transmission using peripheral nerve stimulation or clinical tests. However, and it is affordable, by the way. However, it is frequently overlooked, as you will see in this lecture. Monitoring neuromuscular transmission could be done using clinical tests, which are very popular, or using instrumental monitoring, I mean by use of peripheral nerve stimulator. The common clinical tests, many clinical tests have been described as a surrogate for adequate neuromuscular recovery, hand grip method, or the very popular sustained head lift for 5 seconds. Unfortunately, several publications, including this one, have proved that all clinical tests are not reliable endpoints for adequate neuromuscular recovery. There is one exception, the one described by Aaron Cobman, 1997, which is the tongue depressor test. However, it needs a weak patient and can be only done after extubation. This is a limitation. But if the patient can clench on the tongue depressor, this is almost equivalent to a 3-4 ratio of 0.85, very close to the recommended adequate recovery. Instrumental monitoring, you need a peripheral nerve stimulator to stimulate, a peripheral nerve stimulator, and you can observe the muscle response by vision or touch, or using a transducer. That could be electric or a mechanical transducer to record the muscle response and give you a digital display of the muscle power. There are two types of monitoring or instrumental monitoring: qualitative or subjective. quantitative or objective. Qualitative means you will use your vision and touch to evaluate the muscle response to peripheral nerve stimulation. Hassan Ali, the great Egyptian anesthesiologist who described for the first times more than 50 years ago the train of four ratio. Four stimuli, and in normal you expect four twitches. And he will ask you to count the twitches, and when they are already four, you need to compare the four twitches to derive the train of four ratio. Counting twitches is relatively easy. You can count twitch and it is relatively reliable. The problem comes when you have four twitches and you need to compare them. It has been demonstrated that when an expert anesthesiologist feels by touch or vision that the four twitches are equal, meaning train of four ratio of 1 in the same patient. On the other hand, when you put an objective monitor, the average real train of four ratio is only 0.4. That's why comparing twitches subjectively is grossly insensitive. That's why now they are pushing towards objective digital display of the actual train of four ratio. In a very recent article in Anesthesiology, few days ago, June 2022, they recommended that we have to make a professional practice change initiative to recommend quantitative neuromuscular monitoring. Okay, this recommendation is very well respected. However, when it comes to real life, in most of the setups, neuromuscular monitoring is either not available or it is there, but nobody is enthusiastic to use it. However, this is not only the case in our region. This recent article published in Acta Anesthesiologica Scandinavia discussed the barriers to routine neuromuscular monitoring, and they demonstrated that it is either not available or not in use in most of the globe. Mohammed Naguib, my late friend who passed away in 2019, great neuromuscular man, more than 10 years ago, demonstrated in an interesting survey, himself, Aaron Cobman, and Jennifer Hunter from Liverpool. They demonstrated that in Europe, shown here in gray, 20% of anesthesiologists answered the survey they have never used neuromuscular monitoring. 10% in the States, shown in yellow, never used a neuromuscular monitoring. The question is, why they are not using neuromuscular monitoring routinely? Is it a matter of cost? Is it a matter of reliability? Or it is an overconfidence on the side of the practicing anesthesiologist? I don't think cost is a problem because there is variable types of instruments. Some of them are very simple, as you can see here on the left side of my screen. Very simple. You can get it even as a gift from the neuromuscular company. So cost, in my view, is not that important. Is there a question about reliability? I told you very early, it is the most reliable of the triad to monitor. Several publications proved that monitoring reduces work or post-operative residual causation. This is one of the most recent, published in the British Journal of Anesthesia, meta-analysis and systematic review, which concluded expectedly that neuromuscular monitoring reduces post-operative residual causation, and actually, this is a common sense. What about anesthesiologists' overconfidence? My late friend, the great friend, Mohammed Naguib, also did this survey. He sent neuromuscular questions, neuromuscular monitoring questions on the international level, and he asked the responders to answer the questions and to quantify their confidence in their answer. And the results were interesting. Accuracy of answer was less than confidence, and this proved that anesthesiologists are overconfident with their use of neuromuscular blocker and with their knowledge about neuromuscular blockers. Consequently, if you have neglected neuromuscular monitoring, you will have post-operative residual coronization, and it's much more frequent than you ever think. What is the size of the problem? The famous RECITE study done in Canada and followed by the same study in the States demonstrated that it is a multi-center study, demonstrated that at extubation and the post-operative anesthesia care unit, residual neuromuscular blockade defined as a train of 4 ratio less than 0.9 was 60% in Canada, where the first use of curare was described. Very alarming percentages. If you have work, what are the consequences? You can have early consequences within minutes in the recovery room or PACU, or late complications within days. In the recovery room, you will have the following. This is a very important study by Glenn Murphy, published in Anesthesia and Analgesia. He correlated the train of 4 ratio to the incidence of post-operative critical respiratory events. And he found that patients who have a train of 4 ratio on average of 0.6, far away from the recommended value, those patients are having airway obstruction, severe hypoxemia, which was the most common, pulmonary aspiration, and re-intubation, possibly unplanned admission to the ICU. And it was a cause-effect relationship between post-operative critical respiratory events and residual coronization. Post-operative pulmonary complications are very well covered in the first lecture. This is a late complication. The question of the day. Okay, I have a problem. I am in limited resource country. What should I do to manage safely neuromuscular block? We have a surgeon co-chairing this session, and this is published recently from the surgical literature, Preventive Strategies of Residual Neuromuscular Block in Resources Limited Setting, Systematic Review and Meta-Analysis. I'll give you the outline of their recommendation and my personal recommendation as an expert in neuromuscular blockers. Try to get a neuromuscular monitoring. It could be simple, according or within your budget. I recommend that you have a stock of Sugammadex, again, within your budget. And if you have this stock, I strongly recommend that your main neuromuscular blocker should be rocuronium bromide. And I'll tell you now why I am recommending rocuronium if you have stock, even limited, from Sugammadex. Use Sugammadex as a plan A for reversal in the following clinical scenario based on the literature and based on my own clinical experience. Difficult patient or high-risk patients, high-risk surgery. Obstructive sleep apnea, very sensitive to narcotics and neuromuscular blockers. Obese patients commonly having obstructive sleep apnea, undergoing bariatric surgery. Elderly patients for prolonged surgery. Respiratory cripple, depending on oxygen, difficult airway, or neurosurgery where a cough can end by the patient's life. If I use Sugammadex, shall I eradicate post-operative residual coronization? Yes, according to this important study published in the British Journal of Anesthesia, they compared residual coronization in the PACU in patients who received Sugammadex to those who received neostigmine. All the patients who received Sugammadex have adequate train of 4 ratio of more than 0.90 post-operative residual coronization. Only 50% who received neostigmine reached adequate recovery. What about if I used rocuronium and reversed neostigmine? I ended up by post-operative residual coronization, critical respiratory events, and desaturation. You can go for your stock of Sugammadex, and it is plan B. Use Sugammadex as rescue medication. A very recent article published in Australia Anesthesia Intensive Care demonstrated that the most common 2 indications of rescue Sugammadex were post-operative residual coronization after inadequate reversal with neostigmine and the cannot intubate, cannot ventilate scenario. This is the theory. I'll show you a brief scenario, clinical scenario, in the next few minutes. This is a middle-aged male patient, hypertensive, having AF, COPD, chronic obstructive pulmonary disease, obstructive sleep apnea. He was scheduled for laparoscopic cholecystectomy, and the position mandated that his arms to be tucked on his side. Neuromuscular monitor was there, but it was applied for the ocular muscles because the hand muscles were not available during surgery. This is the neuromuscular scenario. Rocuronium, end of surgery, one twitch at the ocular muscles, neostigmine high dose, atropine, 4 twitches recovered at ocular muscles. Apparently, they were equal, 5-second deadlift, good hand grip, clinical criteria which are unreliable. They extubated the patient. Before talking about the outcome, I would like to answer 4 relevant queries to this clinical scenario. Is it the appropriate timing for antagonism in this patient? Is it the appropriate muscle to monitor during recovery? I mean the ocular muscles. Is it the appropriate endpoint for adequate neuromuscular recovery? Was it the appropriate antagonist in view of the comorbidities? Giving antagonist neostigmine at 1 twitch is not recommended. So gamma dex at 1 twitch in the ocular muscle, again not recommended. It has to be at the hand muscle. But so gamma dex could be given with the recovery of 1 twitch. Giving neostigmine with 1 twitch recovery only, even at the hand, you will need almost 30 minutes for adequate neuromuscular recovery. So when I am allowed to give neostigmine according to the guidelines, you need to have 3 to 4 twitches at the hand to give neostigmine to have adequate recovery in a reasonable time of 10 to 15 minutes. So gamma dex can reverse any degree of block if you give the appropriate dose, appropriate to the depth of block, and you'll get a train-of-four ratio of more than 0.9 consistently in 3 to 5 minutes. Was it the appropriate muscle? Again, ocular muscle during recovery? No. You can shift to the hand and check for the recovery at the hand. Or equal twitches at the ocular muscles adequate? Endpoint? No. Why? Because not all muscles are the same. They respond differently to neuromuscular blocker. And this study, which I done myself, published in the BGA several years ago, the recovery of the ocular muscles exceeded or preceded the recovery of the hand muscles. This study demonstrated that if you use the ocular muscles for reversal, you have 5-fold increase of post-operative residual colorization compared to hand muscles. So, what is the appropriate endpoint for adequate recovery according to this consensus statement? Train-of-4 ratio more than 0.9 at the hand muscles. Was it the appropriate antagonist in view of these comorbidities? Give neostigmine in COPD and have the risk of bronchospasm. Give atropine with AF and end up with serious dysrhythmia. Apparently, neostigmine was not the best choice or suboptimal choice. This is a non-neuromuscular indication for gamma dex. Everything went wrong in this clinical scenario, unfortunately. That's why when nothing goes right, it will go left. And this is what happened in the recovery room. Desaturation, re-intubation. The train-of-4 response was only 3 at the hand muscles. Patient pushed back to the OR, re-intubated. Probably there was no gamma dex, and stayed 1 hour additional in the OR. Why they have this suboptimal outcome? In my view, the monitor was there, but there was no sufficient knowledge about neuromuscular monitoring, and I have pointed this in my editorial to the Saudi journal, Neuromuscular Transmission Monitoring Beyond the Electric Shocks and the Shaking Hands. You need to be knowledgeable. Muhammad Naguib also said, what makes the difference is not the monitor, but the anesthesiologist behind the monitor. The other problem with this scenario was that there was clear indication in view of comorbidities to use the antagonist, I mean the direct antagonist to gamma dex to avoid bronchospasm and to avoid possible serious arrhythmia. The problem also is the compromised safety, I mean the anesthesiologist or the stakeholder, the compromised safety for cost. it ended up by more cost, much more than an ampoule of Sugammadex. 1 hour stay in OR, especially in Western countries, is very costly. And this has been proved in a recent article, Anesthesia Analgesia. Pork in PACU increases unplanned ICU admission and hospital stay. My take-home message is, was this scenario avoidable? Yes. 4 Egyptian American anesthesiologists sent a letter to Anesthesia Analgesia editor, Muhammad Al-Urbani, Hassan Ali himself, Anis Baraka, late Anis Baraka, Ramis Salim. They said that residual neuromuscular block should and can be a never event, provided you have the adequate knowledge of neuromuscular blockers and monitoring, appropriate monitor, preferably quantitative, and use the appropriate antagonist for the clinical scenario. And thank you very much for your kind attention.
Professor Abdul Latif, thank you very much for an excellent presentation and excellent demonstration of a clinical scenarios we face week in, week out. Thank you very much for the presentation. I would like to introduce Professor Jamil Sha'ban. Professor Jamil Sha'ban is a professor of anesthesia. He is the chief of anesthesia at the Clemenceau Medical Center in the beautiful Beirut. He had his fellowship in anesthesia and critical care at the University of California in San Francisco. Professor Sha'ban, the stage is all yours. Thank you very much for being here.
Hi, thank you very much for the presentation. And I would like to thank MSD and all my colleagues for being part on this presentation. Well, I will have to start that Professor Yunus and Professor Abdul Latif made my presentation very easy because a lot of things that apply on pediatric patient also on adult patient also apply on pediatric. This is my disclosure. I work in a hospital which is a private institution but linked to many university, and we have a lot of residents in our institution. We do all kinds of surgery, and we have a big part of pediatric patient coming from a simple tonsillectomy to a major neurosurgical procedure or major abdominal surgery. I like to work a lot on children, and that's why I always and most of the time put myself on their schedule. So as an outline, I would like to present to you a few cases. I would like to talk about the advantage of using neuromuscular blocking agent in pediatric age, about concern of few of my colleagues related to their use, and just to increase the awareness and the hazards of residual paralysis, as mentioned by Dr. Yunus, and to improve neuromuscular management by monitoring, as mentioned by Dr. Abdul Latif, and so enhance pediatric patient outcome. Well, here is where I like to see pediatric, but unfortunately, sometimes we see them in the operating room. We do our pre-assessment in the clinic. We talk with the patient, we talk with the family, and once in our preparation area, we put for them videos. We give them a coloring book just waiting for their surgery, and we made them relax. A member of the family is in them, and you will see that a few of them are very cooperative and accepting the face mask. They have their toys with them. A few other, you will have to hold them with your assistant, and this is the mother holding the leg and the assistant holding the hand because he's refusing to put the face mask. Well, uncooperative child, we see a few of them, they refuse the face mask, they refuse to have an IV inserted, even with the presence of a member of the family. They're agitated and anxious, and the excessive crying most of the time promote for reflexes that might justify the use of neuromuscular blockade. I will be presented a few cases, 4 of them that we worked with the last 2 weeks. Let me start with this premature child, a premature infant, 3 months, with ocular retinopathy. And they started by asking us just to put him to sleep because they need to examine him, and then intraoperatively, the decision to do laser therapy was taken, and here we had to use neuromuscular blockade to intubate him and prevent patient movement in such a sensitive surgery. Well, laser therapy was done and with excellent outcome. But if you can see here, this is the surgeon, and this is myself holding the head of the patient, sitting position with my assistant helping, and the patient was intubated with good outcome for the surgery done. Another quick surgery was myringotomy, adenoidectomy, and here the patient is asthmatic. Knowing that the surgeon is fast, I did not use muscle relaxant. I will tell you about the outcome of all those surgery at the end. This is a third one with foreign body aspiration, 2 years old, with decreased air entry on the right in the right lung and decreased oxygenation. He had a rigid bronchoscopy for removal of foreign body, and neuromuscular blockade was used not to prevent movement and to prevent injury of the trachea if the patient bucked. So another case was a hypospadias with the erythroplasty 3 hour, but most of those cases we do pudendal block. And here, since I'm going to use a nerve stimulator, I did not give him for post-operative pain relief. I did not use any muscle relaxant. So planning and final approach should be according to many variable and criteria. And I will try to justify worry of some anesthesiologists for not using neuromuscular blockade and muscle relaxation used in pediatric age. I evaluated according to my own daily practice and experience, supported from new relevant articles. Well, a few developmental difference, as you know, the neuromuscular transmission is different in the pediatric age group. Their body composition is different. And so infants are sensitive to the effect of non-depolarizing, making prolonged duration of action following administration of it. And infant and children require greater dose of neuromuscular blockade compared to adult due to their larger volume of distribution. The polarizing non-neuromuscular blockade, like the unique mode of action of succinylcholine by sustained depolarization, had a lot of side effects of particular concern, the life-threatening malignant hyperthermia, or in case of young boys, you might have even hyperkalemic cardiac arrest if they have muscular dystrophy. I published a case where we had rhabdomyolysis with a CPK value of 10,000 and more. This patient was a full stomach patient coming for a minor orthopedic procedure, and once given the succinylcholine, he had myoglobinuria, hemoglobinuria, and myalgias, but thanks God, he recovered well after such an incident. So rhabdomyolysis is one of their problems. So if I remember Dennis Fisher in San Francisco, he used to tell us, always have succinylcholine, never use it. And I'm talking about 1986, where I had my fellowship over there. The FDA recommended now to use it only when necessarily in cases of difficult airway, laryngospasm, or full stomach, or in few very difficult cases, like difficult intubation also. Well, related to the non-depolarizing, you might have anaphylactic shock, delayed recovery, inadequate reversal, as mentioned with the post-pulmonary complication, and critical respiratory events and hemodynamic instability. Well, monitoring is a must. And once you don't monitor adequately, your patient might turn into having critical respiratory event, even as we mentioned in the adult and in the pediatric age group. And you will be faced with desaturation, hypoxic episode, airway obstruction, and you might even have to re-intubate the patient and prolong his stay in the hospital if aspiration happened. So there is a benefit. Yes, a lot of us as anesthesiologists like to facilitate intubation and This is supported by a few studies I'm going to mention, and you can later on, and you can for sure facilitate controlled mechanical ventilation, reduce the quantity of anesthetic agent required, and the surgeon, all the surgeon will be happy if you give them a good quality surgical condition and good muscle relaxation. A study that was, it's a meta-analysis on 22 trial, over 1,650 patients in 2020. This systematic review and meta-analysis reviewed intubation condition, and as you can see, all favor for neuromuscular blockade use, and intubation condition was excellent when you are using it. So the use of it is associated with a clinically important increase in the likelihood excellent intubation condition. It goes the same immediately before intubation, that the blood pressure was better and even the heart rate. All are in favor of using neuromuscular blockade. So higher systolic or mean arterial pressure and the heart rate, as well as lower incidence of arrhythmia, were observed in this study on those 22 trials when tracheal intubation was used. And as a conclusion, we can say that the quality of intubation was better and the hemodynamic stability was better. And for sure, when you are using muscle relaxant, more rapid recovery of consciousness can happen. You are not going to rely a lot of sedative and other kind of anesthesia to put your patient more at sleep. So another study done by Park, when they tried to do a tracheal intubation with or without a neuromuscular blocking agent for short procedure, and this is on 114 child, and they divided those patients into 3 groups. Once anesthetized with sevoflurane at a percentage of 3.7, they divided them into 3 groups. A group received propofol 2 milligram. The second group received alfentanil 14 microgram per kilo, and rocuronium was for the third group 0.3 milligram per kilo to determine the optimal anesthetic agent for intubation. And they found out that both when you're using rocuronium or alfentanil, there was superior tracheal intubation, and those compared to the one where propofol was used. And for sure, the hemodynamic adverse event and recovery profile were comparable among the 3 groups. What about reversal? As mentioned, you have the acetylcholine or the Sugamadex, and it goes the same with the pediatric age group. You should make sure that your patient is well reversed at the end. And once in this study done by Tiffany Voss on 288 patients, and this is a phase 4 randomized study, they found out, and this is quickly for our resident attending presentation, the encapsulation, even in the pediatric age, will prevent the side effect of many cholinergic muscarinic adverse events that might be present with neostigmine, atropine, or glycopyrrolate. And the Sugamadex provide a rapid and predictable reversal of vecuronium and rocuronium-induced neuromuscular blockade without directly interacting with the cholinergic system. And here the advantage, and this is quick, since within 1 to 2 minutes in this study, they found out a good percentage, an excellent percentage of patients having a train of 4 above 95. Well, if you are going to use the neostigmine, you might train this at a dose of 50 microgram for over 10 minutes to even 26 minutes in few patients. What about the age group? Whatever it is, from 2 to 6, 6 to 12, or 12 and more, rocuronium, vecuronium, female or male, white or non-white, American or other, all are in favor for Sugammadex use. So pediatric participant in this study found out significantly faster recovery with Sugammadex 2 milligram. And if it is a deep neuromuscular blockade, Sugammadex 4 milligram per kilo was consistent with a moderate neuromuscular reversal, and there was no side effect on all group. And in patient age 2 to 17, this is an excellent way to recover from neuromuscular blockade. Our dear friend in Saudi, they compared this with the neurosurgical patient where they've used it. And you know, in neurosurgery, you need to have the patient stand still, not move, and he might be pinned to the table. So deep neuromuscular blockade is a must. And they found out also that Sugammadex rapidly and effectively reversed the effect of rocuronium once you had reappearance of T2 of strain of 4 at a dose of 4 milligram per kilo. What about this retrospective case study also about the additional reversal used in cases where the patient had not an adequate extubation and good recovery? Well, they found out that the risk factor are extreme of weight, emergency case status, African race, interval, if you gave a dose below 28 minutes, and if the initial neostigmine dose was less than 0.05 milligram per kilogram, or the big dose of rocuronium, all were significantly associated with administration of additional reversal. And this is Sugammadex neostigmine at this number on 6,300 patients, where they needed to give extra additional dose on 100 patients. Monitoring, I will not go over it. It was very well covered by Professor Abdul Latif. Qualitative, quantitative, for sure. You need to make sure that the clinical signs are not in pediatric age group even as good. Head lift, chin lift is not good. What you should have, please play video. So this is above 9 strain of 4, and here you can extubate your patient, and the strain of 4 will give you a quantitative and not qualitative. So I will finish by talking about whenever they've done a study on age-related physician, if it is less than 5 years, they found out that those anesthesiologists used more Sugammadex than older anesthesiologists, and this is done Sugammadex is commonly used in pediatric anesthesiologists, fewer years of practice compared to the other anesthesiologists. Well, to go back quickly to my case reports, ocular retinopathy patient had Sugammadex. He is a premature, 3 months old, but he had an uneventful extubation and he was monitored. Sugammadex was given for reversal. The case with myringotomy, it was an uneventful extubation. The case with foreign body aspiration had a reversal with Sugammadex and had adequate respiratory effort and saturation with no side effect. The case of urethroplasty had a 3-hour procedure, and here there was a delayed extubation time with uneventful recovery. Let me show you the case video again, please, if we can play. Patient with bronchoscopy, and here, if you are going to use a rigid bronchoscope, I cannot see myself anesthetizing this patient without muscle relaxant, because if he bucked or moved, we might really end with a very bad tracheal injury, and I'm always using this on my patient whenever it's a rigid bronchoscope. So neuromuscular blockade used for better intubation, more surgeon satisfaction, ease in completing surgery, and use of Sugamadex facilitated extubation, and a recovery time was shorter. Whenever you are not using, you might have worse intubation condition, less surgeon satisfaction, and the excessive use of induction and maintenance agent might cause delay in recovery. So as a summary and to finish, pediatric age group still represent a challenge during general anesthesia related to the use of neuromuscular blocking agent and the reversal of its effect. The decision of using neuromuscular blocking agent should be take in consideration your concern as well as the surgeon concern. Method to reduce the risk of post-operative residual blockade should be taken in consideration. And again, association between residual blockade and major adverse respiratory morbidity and mortality are important. Monitoring again is very important. And please, reversal agent are a must even in this age group to prevent critical event post-operatively. And thank you very much.
Thank you very much, Professor Shaban, for an excellent presentation. I have a lot of admiration for pediatric anesthetists. You know, I must admit, I love the picture with this premature baby standing on this slit lamp. This is just fantastic, amazing. Well done, great work.
Good afternoon. Excellent first part of this meeting, and I would like to congratulate all the speakers. And now let's move for the second session with the first lecture. We have Professor Dean Gobaland, who is the head and chief of the anesthesiology and critical care of the University of KwaZulu-Natal in Durban. And he will talk about the effect of the COVID-19 pandemic on anesthesia practice, what happens post-pandemics. Professor Gobaland.
Thank you very much. Good evening, colleagues. It's a pleasure to be part of this meeting. Greetings from South Africa. I've been asked to give you some thoughts about what happens post-pandemic in terms of anesthetic practice. So let's get going. These are some of my disclosures in terms of my having a role as a speaker faculty and or part of advisory boards of the following companies. But really, what I'm going to tell you is my opinion in terms of this view on what happens in the post-pandemic period. So let's talk about anesthesia practice post-COVID-19. This has come along and shaken all of our lives in such a way that it has to have had an impact. Uncertainty is a very interesting phenomenon. We often find ourselves in this space. And Judith February actually summarized this quite well. In the face of uncertainty, it's often instinctive for us to try to predict the future. And we do so either as a soothing salve, it makes us feel better, or as an ode to deep pessimism because we think the worst is going to happen. So we often want to predict what's happening. So let's take a look in our crystal ball and see what the world looks like, especially in terms of anesthesia practice after SARS-CoV-2. Benjamin Franklin said, out of adversity comes opportunity. And really what you do with that opportunity is up to you. The opportunity is there, and it's up to us to grasp the opportunity. Of course, as part of the pandemic, all of us, even if we had no experience before this, became armchair epidemiologists. And this would include our patients and the general public. In fact, we even became armchair pulmonologists, armchair pharmacists, because everybody in the world knew everything about COVID and all the drugs that go in terms of managing it. So these kinds of concepts were not foreign to the general public anymore. People had heard of what ARDS was. They knew what critical care was. They knew about mechanical ventilation. and it changed the world in many ways. Our patients will have changed, in some cases for the better, and in some cases, you might argue, for the worse. How have they changed? Well, they've become empowered because they become educated, which is a good thing. But of course, you know the challenges when all our patients become Google qualified doctors and what that means for us as clinicians. The whole pandemic has highlighted patients' rights and how important they are. But it's also forced the medical fraternity to move away from the paternalistic approach as patients have become more empowered. So in this post-pandemic period, we can expect to deal with patients that have significantly changed. Of course, this hierarchy in which we exist as part of anesthesia and critical care was turned on its head, where society becomes the top, and we have to focus on that. These four aims haven't changed, however, and these goals of improving patient experiences, lowering the cost of healthcare, improving clinical outcomes, and improving staff experience remain as important as they always were. I refer you to this excellent article that took a look at pandemics and how they've shaped the development of anesthesia and intensive care medicine. So let's look at some of these in a little more detail. There's 9 such scenarios. In the early 1800s, the cholera pandemic was rife. And O'Shaughnessy and Latter were instrumental in developing IV saline. And that pandemic set in motion the clinical use of IV fluids. A few years later, in the mid-1800s, the diphtheria pandemic was rife. And Boucher and O'Dwyer were instrumental in developing intubations for their patients that developed obstructions from the diphtheria membrane. We take that a little forward into the 1918 Spanish flu. And yes, oxygen was being used before this, IV fluids was being used before this, and so too was sedation. But what the pandemic did is that it brought that to the fore, increased its utilization, and developed that further. The poliomyelitis pandemic of the 50s, we all know, Ibsen and anesthesiologists by trade made great strides in mechanical ventilation, which was the forerunner of the current ICU. He developed the anesthetic observation unit, which then became the critical care unit. And the pandemics of the mid-20th century also had an impact. Especially the Hong Kong flu in the late 60s was instrumental in taking mechanical ventilation further, as around the same time Ashbaugh described ARDS. If we take that a little forward, the HIV/AIDS pandemic, which of course is still very much within us, and South Africa is in many ways the capital of the world in terms of this disease, it's emphasized the holistic management of patients, but also emphasized the need for universal precautions, the use of disposables within our workplaces, and how we manage our shops. Even the variant Creutzfeldt-Jakob in the mid-90s had an impact because it forced us to go back and look at how our equipment was being sterilized. And SARS-CoV-1 in the early 2000s made us focus again on infection prevention and control and PPEs. So where does SARS-CoV-2 take us? Now, the only other thing that's made such an impact on the way society has developed and healthcare has progressed is, of course, the effect of war. So I've chosen 9 quick areas that I'll tease your minds about and think about them in terms of how COVID might have an impact. The first is research. And research is formalized curiosity. It's poking and prying with a purpose. I love that definition of research. And SARS-CoV-2 has certainly given the world's scientists a purpose, a concentrated purpose like never before. You know how much research happened in a short 2-year period. These authors suggested how science will transform after COVID. Research funding needs to be rethought. Which research is funded needed to be re-envisioned. We need to reimagine the way we publish the science, and we need to reconsider how we communicate science. And these are stark lessons that we learned throughout the COVID pandemic. So this space is likely to evolve significantly. An interesting look at over 2,000 scientists, policymakers, and members of the public in terms of what they expected the future world of science would do following the pandemic. And if you focus on the green on that slide, that's the majority of people thought that science will be strengthened following that. Now, that might well happen across the spectrum, or it might even happen within our space. But we learned some very harsh lessons. For the first time in history, a number of articles were retracted because we needed to beware of the preprint. So we needed to focus on what is being said. With the establishment of social media, this was a major concern. The second area is COVID. The COVID pandemic will significantly change the design and health of where and how we work. So our theaters and our ICUs and the hospitals of the future are going to be networks with importantly flexible capacity, because that needs to happen as the situation changes. And we learned that lesson in COVID. But there'll be a single digital infrastructure that works as the network binding this whole various components of the healthcare system. ICU without walls, is an old concept, but the COVID pandemic taught us that our practice can't be restricted into specific areas. And we will have to look at how we enshrine such practices in areas outside our areas of normal practice, outside theater, outside ICUs, and how that happens. Touch-free controls of lighting, temperature, and other building operations, the removal of curtains and replacement with smart glass or e-glass are all have already started changing, but will get entrenched in this post-COVID phase of how our theaters and our ICUs look. About infection control, there's nothing that has focused us, and including the general public, on infection control in terms of masks and hand washing. I'm sure all of you probably have rashes on your hands from having used all this alcohol for 2 years. But infection control is a key part in terms of compliance, in terms of the challenges that we have, and in terms of how worker behavior will change. What does that mean for us in anesthesiology? Well, I don't know about you, but many anesthetists the world over in the pre-COVID phase had been moving away from masks, saying we don't need to wear masks, the surgeons need to wear the mask over the operative field. But the sense is that certainly within the theater context, mask use will increase, if for nothing else, for our protection indeed. Hand washing, I need not say any more about that and the importance of that the pandemic would have entrenched in our practice. What about the digital transformation? So yes, I will accede that digital transformation happened well before COVID. But the truth is that these platforms, we never heard of them, or we'd only heard of them in passing, and yet they are intrinsic parts of our daily lives today. We've moved into this area where even our assessments and our College of Medicine of South Africa have run online exams during the COVID period. And so too has this meeting. In a pre-COVID era, we would have probably all needed to fly to a central destination. Yes, that would have been great to have seen all of you. But the convenience of the electronic virtual platform has certainly made accessibility much greater. And these kinds of changes in terms of the digitalization are most likely going to remain in some form. And that's happened with DigiHealth as well, and with telehealth, in terms of how we communicate both with our patients, with our colleagues, with the way patients get referred to us. The COVID pandemic has forced us to make sure we do this and do this effectively. Supply chain is an area we never quite think about, except when you want that laryngeal mask and you don't have any availability in theater, or you're looking for the Sugamidex and you're out of stock. And what COVID has done is that it's forced us to think about how we can optimize supply chain. The need, for example, for regionalization of supply chains rather than the old traditional model of central stores. Of course, we don't want a situation where we have this excess of stuff when we don't need it, or, heaven forbid, on the right side, where old Mother Hubbard goes to the cupboard and it's bare, is an equally distressing situation. And we don't want that to happen as well. What of anesthetic caseloads and techniques? Well, let me share with you our theatre data in my province of KwaZulu-Natal in South Africa. And this goes from the last 8-year period. You will note in terms of the change during the COVID period. The orange reflects the non-cesarean section cases, and the blue, the cesarean section cases, with the dip in the non-cesarean section, but the cesarean sections have continued increasing. It's taking some time for this to come back together because of the lack of resources within this space. These authors suggested that there might have well been a change in technique because they had described an increased use of regional anesthesia. Certainly in terms of a 13% fall in the use of general anesthetics and an equivalent increase in regional anesthesia. There was no significant change in anesthesia for cases, of course, like laparotomies, because those were still being done under general anesthetics. But certainly for the cesarean sections and other cases, there was a significant increase. And at the same time, a statement was put out by Azra and Ezra entrenching the value of neuraxial blockade as part of how we manage patients. Now, what does this mean? Does it mean that we will stay with this practice? Does it mean we will change? It'll be interesting to see what happens in this next period. Equally, specialized airway management, which has always been the forte of anesthetists, has come to the fore. And anesthetist-led airway teams, we know in the COVID era, were paramount. And that was a key drive for ensuring safety. The role of rapid sequence intubations was increased, as we didn't want patients breathing out and increasing the chance of aerosolization. There's a shift in how people practice in some areas where anesthetists would move patients into the PACU before they got extubated. The tendency was to manage them within a more confined space. Closed suction systems and filters were reaffirmed as being integral parts of what we do. Education and training also changed significantly because we needed to do things that we didn't do before. We know that our trainees who went through the system across the world, and this was a look amongst anesthesia trainees across many countries, including South Africa, which demonstrated that there was a significant change in how they were being trained. The digitalization of many aspects of their training, they felt, were unlikely to be reversed because of the accessibility and convenience issue. So training is certainly impacted significantly. What of triage? Well, we learned how to triage better. The one on the left indicates a plan that we'd made for the country on more rational utilization of resources. So the expectation in the post-COVID phase is, having learned how to triage better, that we might well be able to do this much better when we have situations of the same. And I think here of major trauma situations, of patients needing ICU in the face of non-beneficial or futility assessments, triage becomes key. Inherent in that is palliative care, and our role has certainly increased as palliative care has become more important, especially our role as anesthetists who have a key knowledge of pain and pain management. In this space where palliative care is increased, certainly we will play an increasing role. And the last point I want to emphasize is the value of healthcare workers, because there's a mismatch. There's a distinct mismatch between social values of what key workers do and how they get remunerated. There's a market failure to value adequately what really matters. This is an excellent book to which I refer you by David Zweig. It's called Invisibles, and it celebrates the unsung heroes of the workplace. And one of the best examples he uses in this book are anesthesiologists, because we are unsung heroes. We are often invisible. And there's an interesting element to this. There are three traits that are common to those excelling in invisible roles. There's an ambivalence toward recognition, there's a meticulous attention to detail, and there's a willingness to assume responsibility. And if you think about it, those three traits very appropriately describe anesthetists the world over. It would be remiss of me if we didn't recognize all our colleagues that we've lost during this pandemic, who have given their lives, who have given all in terms of this. So the role of anesthetists and the importance of ourselves as a key part of the team has certainly been emphasized. With that goes this importance of wellness. And the COVID pandemic has taught us the wellness and our aggressive management of the wellness of our workers is paramount. We can't move away from that. And that's fundamental to what we do. We have to protect ourselves. These two excellent commentaries and editorials have emphasized how we've come to the fore, how we lose our shadow of invisibility, according to Schweg. This is the rise and rise of anesthesiologists under the shadow of COVID and bringing out the best in anesthesiologists and looking forward to the future. So what COVID has actually done is that it's brought us to the fore. So if we go back to this pandemic thing, we can add to our box, and these authors suggest that there are a couple of things that these have done, that SARS-CoV-2 has done. It's emphasized anesthesia-led teams, especially the airway teams. It's also emphasized an out-of-theater role for us in many ways. It's emphasized PPEs. It's emphasized safety. It's emphasized IPC. So there are a number of elements that are being entrenched in this post-COVID phase. I'm almost at the end, and I want to quote Arundhati Roy, the famed authoress, who talks about the pandemic as a portal. Historically, pandemics have forced humans to break with the past and imagine their world anew. This one is no different. It's a portal, a gateway between one world and the next. And as we move into this next world, hopefully we have learned from where we come. Of course, people are sometimes stubborn to change, and the status quo might well remain. I'm hoping that we've got this big disruptor called COVID that has shaken us in the right direction. I'm going to leave it there. Thank you very much for your attention.
Thank you very much, Professor Gobalan, for your excellent presentation. And now let's move to Dr. Ibrahim Mohammed Hassan, who is an anesthesiologist and the head of the acute pain service at Dr. Sulaiman Al Habib Hospital in Riyadh. And he will talk about Tower of International Guidelines role.
Thank you very much, Mr. Chairman, and thank you very much, MSD, for giving me to participate in this event. This is my disclosure. I'm working on this big hospital, which is Dr. Sulaiman Al Habib Hospital, and it's considered very big bariatric private service, private hospital, which is doing big cases of bariatric cases and also orthopedic cases, and also MSD, but this doesn't affect the content of the presentation. In the beginning, we are going to discuss what is the clinical guidelines. Clinical guidelines was defined by the World Health Organization as a systemically developed evidence-based statement which assists providers, recipients, and other stakeholders to make informed decisions about appropriate health interventions. Okay, the clinical guidelines, the term implies for a careful search for relevant literatures, also explicit procedures for forming recommendations, and reproducible measures for appraising and validity and applicability of the findings. Clinical guidelines is not only guidelines, but it's also standards, protocols, recommendations, and practice advisories. Clinical guidelines, there should be a link between the evidence and recommendations. We are going to show one example for this. This guideline, which is published by the European Society of Anesthesiology, which is about the preoperative fasting in adults and children. This guideline was showing a successful link in its recommendations to research evidence. Another example, this guideline, which is management of proximal femoral fractures in 2011, association which published by Association of Anesthetists of Great Britain and Ireland. There was no search strategy actually, and there is no definition of clinical pathway of multidisciplinary care of particular patient group. Also, there was no details on how its conclusion were linked to research. Another example, there is a difficult airway society guideline for management of tracheal extubation. Actually, this guideline was depending only on personal experience of anesthetists. There was no link between evidence and recommendations. And the author produced a pragmatic summary of expert opinion reviewed by relevant practicing anesthetists. Guidelines, as it has advantages, it has disadvantages. And we shall know what is the advantages of using our guidelines. As well, we must know what is the disadvantages of using guidelines, and through it, we can choose which guideline can be good to follow. The first advantage of using guidelines is to facilitate the practice of evidence-based medicine. Also, it provides a practically oriented summary of prevalent research literatures. Also, they can reduce variations in practice. Another advantage, they discourage the outdated and inefficient practice. Also, it improves the efficacy of healthcare delivery. Also, it's freeing variable resources. Another advantage also is raise awareness of the anesthetists. Also, it's a source of practical advice. And it can be standardized clinical management in departments, countries, and also continents. Let's go for disadvantages of using guidelines. The guidelines is usually prepared and designed for average patients. Some of our patients, you cannot apply these guidelines if they are in a particular group, and this is considered one of disadvantages. Also, it limits professional judgment, they are too prescriptive, and there is some conflict of interests of the guys who are putting these guidelines. Also, there is some difficulty of implementations. Let's say some guideline says in cases like total hip replacement, the guideline is to say put something like fascia iliaca block. Fascia iliaca block, not all departments has personnel or equipment which can give this block. So this guideline is a misleading guideline. So the difficult implementation can be under the lack of expertise in using particular interventions, or in disarrangement with the recommendation, and also in problems in identifying necessary resources. Guidelines also can be different. It means ESRA guidelines can be different from the ESA guidelines, which is makes the physicians and the anesthetists sometimes get confused. Another thing that they judge on the quality on the guidelines on the source or the paper which is published on. So when you have a guideline published on the European Journal of Anesthesia, or British Journal of Anesthesia, so it's a trusted guidelines, which actually is not 100% true. Or another disadvantage is that high quality guidelines are sometimes very expensive, and it increases the cost of the service. So what do we expect from the guideline? Guidelines should address practical questions and problems and be short and concise as possible. Also, new guidelines should state why they have been produced, and they add to existing guidelines, okay? And another thing we shall expect that it requires expert opinion to set the research evidence in the clinical context and produce an authoritative recommendations. As we mentioned before, there was one guideline, one of the examples we mentioned before was depending only on the experts, but good guidelines actually should depend on experts and clinical research. Also, we should be told if guideline group have a conflict of interest, and else the guideline should be reviewed outside the society. For example, the European Society of Anesthesiology, they are doing web-based peer review before publishing their guidelines. Also, the guidelines should be reviewed periodically to ensure that the advice they offer are still current. Now let's take into a tour, which will be a very fast tour because of our timing, to very recent international guidelines we have. This guideline, which is published in the European Journal of Anesthesia in 2022, which is according to regional anesthesia in patients with antithrombotic drugs. First question, why the European Journal of Anesthesia has to publish this guideline? Actually, these old guidelines published by European Society or ASTRA or whatever, we have some new drugs like Abrixpan, like Rivaroxaban, which is a new drugs used as an anticoagulant drugs. These drugs there was not enough researches according to these guidelines, so there was a need to publish a new guideline. The usual antithrombotic we know is low molecular weight, heparin, unfractionated heparin, aspirin, antiplatelet like aspirin, B2Y12 inhibitors. The traditional approach to patient safety was to calculate the time before and after intervention. Actually, the new guideline, they have a new advantage that they categorized the blocks into superficial and deep blocks. So some of the blocks, it depends if you are doing a block which is superficial block or a deep block. Accordingly, you decide at what time you are putting your you are going to do your intervention. When we take a very fast and quick overview on the guideline, on this guideline, we see a lot of numbers. Actually, these numbers are not made to confuse you. These numbers are made to help you. You don't need to know every word of this guideline. Just when you see a patient and this patient has an antithrombotic or anticoagulant, and you're going to give a block to this patient or you're going to do an intervention to this patient, just open the guideline and see the numbers and behave accordingly. Another guideline here, which is a very recent guideline also from the European Journal of Anesthesia, which is published in 2022, which is discussing the preoperative fasting in children. Actually, this guideline, why we needed this guideline? Because there was some new researches, and these new researches, if we see here, this research is about low incidence of pulmonary aspiration in children allowed to intake clear fluids until the time of the operation. In this research, it was done on about 10,000 patients. We see here there is only 3 patients had risk of aspiration, which is very low number, and these patients were allowed to drink water until the time of the operation. So we have to rethink. The old strategy was 6-4-2. The 6-4-2 strategy, which is 6 for light meals, 4 for milk, breast milk, and 2 for liquids, has to be rechecked again. Another research here is another paper which shows that from 1 to 2 hours has less. Actually, this patient was checked by ultrasound, has less content in the stomach. So no need to keep to let the patient to fast for 2 complete hours in the according to the previous guideline. Also, another research was done on breast milk. You see here on this research, the half-life of the milk was about 40 to 60 minutes. And on the other research, we are speaking about 60 to 90 minutes. And after 120 minutes here in both researches, with ultrasound, gastric ultrasound, you see the stomach is empty from the milk. So why is the need to keep the baby fasting for complete 4 hours, while after only 2 or maximum 3 hours, the stomach is already empty from milk? Another research here which makes them rethink about doing a new guideline is about the solids after eating a light meal. We see here after 60 minutes of the meal, the stomach is filled of fluids, but after 240 minutes, means after 4 hours, the stomach is, if we compare it to the fasting state, it's like the fasting state. It's completely empty. So why is the need to make the patients fast for complete 6 hours? So this guideline puts some recommendations and some standards. If we have a fast look here in this recommendations, they recommend that the fasting should be only for clear fluids less than 2 hours. And there is another recommendation regarding the breast milk. They are speaking about 3 hours only for breast milk fasting. And regarding the solids, they are speaking about 4 hours only fasting. And there is another recommendations for specific group of patients and for specific comorbidities. Let's go for another guideline, which is difficult airway guideline and awake tracheal intubation, done by Difficult Airway Society. This guideline is putting some like a recommendation for the technique to oxygenate, to perform, to oxygenate, to bicalize, perform, then sedate. And they put also some guideline for the management if the intubation, the awake intubation is failed. So this guideline, what would we do if we fail to put the intubation? Let's go here. Also, there is some recommendations which is done by the Anesthesiologist Association of Anesthesiologists. And in this guidelines, one of the points we want to speak about is the quantitative neuromuscular monitoring. Quantitative neuromuscular monitoring, they speak about the train of 4 TOF should be monitored through all the times of anesthesia until the TOF more than 0.9. Now let's speak about the national and the departmental protocols. Let's take some examples. This guideline, which is done by the Italian Society, which describes preoperative management in elderly patients, and they have recommendations for elderly patients. Some of these recommendations will be highlighted, like the depth of anesthesia. Depth of anesthesia, actually, they recommended the use of EEG in all elderly patients during general anesthesia or during sedation to avoid delirium. Also, they have some recommendations, residuals of preoperative neuromuscular blocks. They recommend the use of Socomedex as a reversal of neuromuscular block, and they recommend to monitor the patient until the TOF is up to 0.9. TOF is up to 0.9, and also in patients who failed to return with neostigmine, they advise to use Socomedex as an additional drug to make sure the patient is completely reversed. Another example here is by the French guidelines. These French guidelines using muscle relaxant reversal. These French guidelines has some recommendations regarding muscle relaxants. Let's highlight some of these. Actually, they speak about deep neuromuscular block and motor neuromuscular block. And they said there is no, until now, there is no sufficient data to decide to use deep or moderate neuromuscular block. Also, they have recommendations to use the adductor muscle of the thumb until the patient TOF ratio is more than 0.9. And also, they have some recommendations that the neostigmine should be maintained given if the TOF more than 0.9. And another recommendation, the Sugammadex dosage should be calculated on the ideal body weight of the patient. And another recommendation also that the qualitative neuromuscular monitoring should be probably maintained after Sugammadex administration and to detect recurralization, because Sugammadex alone is not a guarantee that the patient is fully reversed, and you need to monitor these patients. We have here also another guideline, which is done by the Saudi Anesthesia Society. And this guideline was or protocol is enhanced recovery after anesthesia protocol done by Professor Dawlatli. They are making like a step ladder here, starting by background, which has a triangle of risk assessment, optimization of the patient, and education of the patient. Then go through the preoperative period and how to assess your patient in the preoperative period, and they go through the intraoperative periods, and they are speaking here about neuromuscular monitoring and using rocuronium and Sugammadex as a reversal agent in these patients. Lastly, I'm going to show some protocols which I'm actually using in my hospital, and is like a local protocol. As I was introduced by the chairman, I am leading the acute pain management service in my hospital, and the acute pain management, actually, we are holding more than 250 patients in our hospital, and we needed a protocol to follow, and this protocol helped us too much, because if you see here, the protocol A and P is used usually by the ward nurses, and if the ward nurses follow these protocols, by the end, we are speaking about 10% only of our hospital patients is under our care, and so it decreases the burden of on our service in our hospital. Thank you very much for your attention, and thank you, Mr. Chairman.
Thank you, Dr. Ibrahim, for your excellent presentation. And now the next speaker is Professor Madhat Shalabi, who is the founder and the president of the Pan-Arab and Middle East Enhanced Recovery After Surgery Society in Dubai. And he will talk about tactics for implementing enhanced recovery protocol after surgery in real practice. The floor is yours, Professor Shalabi.
Nice to be with you all, and it's my great pleasure to be one of the speakers among this elite group of speakers. I will start by my disclosures, and then I will start by a very important quote from Victor Hugo, who's a French poet, who once said, "An invasion of armies can be resisted. You can resist an invasion of armies, but you cannot resist an idea whose time has come." And by this idea, I mean definitely enhanced recovery after surgery. This is very important. So, what is enhanced recovery after surgery? I know many of you will know definitely what it means exactly, but I wanted to put the definition because it's very important to understand the definition. Enhanced recovery after surgery are protocols. So they are protocols, and thanks to Dr. Ibrahim, the last speaker, he introduced the idea very, very nicely, and I cannot find any lecture before my lecture which is better than his lecture. So thank you, Dr. Ibrahim. So they are protocols, and these protocols are combinations of, number one, they are evidence-based. So anything we mention or we say in IRAS is to the best evidence at the time of the publications or at the time of writing the recommendations. And I was one of those who put the recommendations and guidelines of the IRAS Society for cesarean section, and I know exactly what hard work do we have to do to get the best available evidence. And we should be in a situation to understand that maybe 1 year, maybe 5 years, maybe 10 years along the line, the level of evidence change, and say that what we are doing is not the best evidence, then we have to be flexible to go for the best evidence. So they are all evidence-based, and they are perioperative, which goes hand in hand with the anesthesia. Anesthesia departments worldwide now are called perioperative medicine departments because they start pre-operative, intraoperative, and postoperative together, and they work together synergistically. And synergistically means 1 + 1 = 4, not 2, because they help each other. You should use them in the form of a package together to have the much better effect. And they markedly improve the quality of recovery and the speed coming as a byproduct. It started originally as fast track surgery by Professor Henry Kellett, and the name thought that fast track gives an emphasis on the speed, so they call it enhanced recovery to say that it's more about the quality, and the quality will produce speed. And we can see here this logo of the IRAS Society, and this is based on actual research that the neuroendocrine stress response in a normal pathway will cause some deterioration in the body function, and if we follow the IRAS, it will be much better. And I used the same logo because this is based on actual research on the Pan-Arab and Middle East IRAS Society. Now we are in a healthcare challenges because there are lots of aging population. Every country in the world saying we have diminished funds, so we are in need of better care for less cost. And we know that behind the cost, the most important are the post-operative complications. You can see if you have 2 complications, the cost will double. If you go for 3 or more, the cost will be multiplied by 7. So this is the most important cause of health expenditure. In IRAS, we reduce the non-surgical complications such as the chest infection by about 60%. And in the medical complication, the surgical complications such as wound infection by 40%. So reducing this dramatically, as you can see, will cause lots of savings. And this was shown in New Zealand. There was a saving per case of $4,500. In Switzerland, about $2,000. In Canada, about $3,000 per case, per single case. So this will let you know that the cost of a drug or instrument or using a guideline which needs a bit of cost is totally justifiable, because it actually, as you can see here, it's the best return of investment thing you can ever have. A quality improvement with the best return of investment. Now, what is the role of the anesthetist? As I said, it's perioperative, pre, intra, and post. So in the pre-operative assessment, we start our role, and then we do what we call patient optimization and then we intraoperative for anesthesia and postoperative, immediate postoperative care and looking after the patient till discharge. In preoperative, there are some modifiable risk factors which we look at, but more important is patient engagement. That's why if I go to a center, assuming they are doing ERAS protocols, and I ask the patient, do you know that you are a subject of ERAS protocols? If the patient say no, then this place does not apply proper or does not implement the proper ERAS. So patient engagement and patients in ERAS are partners in their care. After that, we look at the big five. Anemia should be corrected. We should correct diabetes. If the patient is malnourished, extremely important, hydration and carbohydrate load and the blood pressure control. These are, any one of them, I can give a lecture about it. I am just trying to enumerate to you the things which are really important. Then, after the preoperative come the intraoperative evidence-based ERAS elements, such as antibiotic prophylaxis, avoiding the nasogastric tubes, the post-operative nausea and vomiting prophylaxis, short-acting anesthetics, the maintenance, the depth of anesthesia where appropriate, protective lung ventilation. We'll talk about them or about the most important among them. Maintenance of normothermia here is really important. This is something which I like to make sure every place is doing it. So the analgesia, the goal-directed fluid therapy, normovolemia, maintain hemoglobin, loads of things. Nasogastric tubes, I said before, they are not routinely done. You have to justify, the surgeon has to justify the presence of a nasogastric tube post-operatively. I can give a lecture about this only. Reduction of post-operative nausea and vomiting, very important. We try to minimize post-operative nausea and vomiting, and if you follow the ERAS protocol really, then the incidence, I cannot promise my patient that they will never have post-operative nausea and vomiting, but we can reduce it below the basic in the world, below the benchmarks of the whole world. Post-operative them, apart from using bimodal like dexamethasone and one of the citrons in them, we also use in the reversal, if you are going to use of course we use regional technique to minimize the opioids and opioid sparing. I will talk about that, but we need to residual muscle block with sugamidex rather neostigmine, because neostigmine causes more nausea and vomiting, which we don't want. And sometimes we have to use Tiva for that. Tiva for as anesthetic technique. The goal in anesthetic management is to facilitate rapid emergence by using short-acting anesthetic agents. This has been shown to accelerate the recovery and reduce the length of stay in the hospital. So when we use short-acting, we try to use the most short-acting ones, like desflurane rather than sevoflurane. I can give a lecture about that and how important, and with the green OR, this is another subject which I can give lecture on. And then we maintain, and after that, very important, is when you need muscle relaxation, you use a muscle relaxant with a shorter duration. If you are using a muscle relaxant, you should here monitor the muscle relaxation intraoperative. You should monitor. This is a must. And in the first session where Professor Abdel Latif was talking about that Miller saying that, it's not only Miller, this is a must. If you're not doing that, you are liable for medico-legal problem. So monitoring of the neuromuscular relaxation, and at the end, the full reversal of the neuromuscular relaxation. This is a must. There is no joke in that. And the cost, as I explained, is totally justifiable. It's actually needed that you should do that. The depth of anesthesia as well, I use nearly routinely, not in every case, but nearly routinely, even with inhalation and anesthetic, a depth of anesthesia monitor to avoid giving this patient more anesthesia, not only to prevent awareness as we used the depth of anesthesia monitor before, but more importantly now to avoid giving the patient too much. It's individualized. And in the lecture of Dr. Ibrahim, who mentioned about that guidelines are talking about average, not a single patient. The guidelines of ERAS are aiming to individualize the treatment and the drugs given in ERAS to a single individual patient, and that's why they are very successful. Here in ERAS, I said this is totally important, and I give not only one lecture, 10 lectures about maintaining the body temperature. In the last 15 years, I didn't have a single case of shivering. And I promise all my patients that shivering is preventable, not curable. Preventable. Of course, you know about the protective lung strategies, thromboembolic prophylaxis, whether non-pharmacological or pharmacological. In analgesia, you know better than me that our aim is to reduce the opioid consumption and give the patient the best analgesia, aiming for optimized patient comfort, fastest functional recovery, and diffuse side effects. And we encourage post-operative dreams, drinking, eating, mobilizing, and sleeping. Post-operative, very important. So this is our aim. And the key word is opioid sparing, minimal possible opioid. When we come to the fluid, too much is not good. Hypervolemia and bowel edema. Then they started looking into restrictive fluid, and this led to bowel ischemia. So we have an optimal niche here of fluid management for the patient. This can be like 100 lectures about the fluid. So we have this niche. We give fluid only for a fluid responsive patient, and we can know that by implementing and using non-invasive cardiac output monitors, which in my opinion will be the future in monitoring rather than the blood pressure. So we will monitor cardiac output by non-invasive cardiac output monitor. And the aim is to give the right amount of fluid, not too much, not too less, the right fluid at the right time. And aim of an anesthetist during surgery is to provide to maintain the vital organ nutrients and oxygenation and give the best performance of the surgeon and facilitate and achieve at the end a full recovery. Also, we would do our best to minimize any drop in the blood pressure because we want to keep the blood pressure reasonable one for the patient. Simply, early mobility, and early mobility comes by full reversal and full reversal of the muscle relaxant and the full end of the anesthetic agents. Then we will have enhanced recovery, which will lead to decreased length of stay, healing, and the decreased complications. Laparoscopy now is the goal, is the minimally invasive surgery is the most important in ERAS. This is the surgical part. And minimally invasive procedures can be associated with restricted surgical conditions, of course. So some of the surgeons will need and demand deep muscle relaxation. In this situation, as I told you before, you should monitor. But if you are using a muscle relaxant, you should monitor anyway. But you should monitor and you should have full reversal at the end. This is extremely important, and it is significantly, if you don't have a full muscle power back, this can significantly prolong recovery, increase risk of serious clinical complications such as chest infection and postoperative pulmonary complications. Residual neuromuscular block may prolong the postoperative PACO1, and this is long, and this is some of the most expensive time in a hospital. So giving a drug which antagonize the muscle relaxant is totally justifiable, because if the patient stay in recovery long with neuromuscular block effect, the hospital will pay much, much more than that. Ladies and gentlemen, to summarize, ERAS is the present in the developed countries and the future of perioperative care all over the world. It is evidence-based to the best available evidence at all times. It is certainly the right and the good medical practice which constitute our duty of care to our patients. It's a duty of care. It markedly improves patient experience, patient outcome, and patient satisfaction. And the patient is the center of what we need now. Above all, it provides the best possible perioperative care to our patients, and at the same time, cut the cost and save lots of money, essentially by reducing both the medical and surgical complications, as I showed you, dramatically by 40 to 60%, which will lead also to shortening the length of hospital stay with its concomitant reduction in readmission rates. It is a dream coming true, applying the best possible care and cutting the cost. So why not everyone is implementing ERAS? This is because of what we say, the know to do gap. We know the knowledge, but it takes us long time to do it. And this is our responsibility and the duty. Seminar like what we are in today is the most effective way by which we spread the right word, increase awareness, recruit lots of leaders who lead the role model and by example. Every one of you today can start to become a great leader and the ERAS champion in his or her place. Ladies and gentlemen, it's an honor talking to you. Thank you very much for being such a great audience.
Thank you very much, Professor Chalabi, for your excellent presentation. And as I said in the introduction, as a surgeon, we need good curization for good surgery. Thank you very much for all. For me, as a surgeon, it's very important to have good relation with anesthesists, and it is important for us to implement ERAS in our department, because as you say it, it's improve the quality of the comment on dit, la prise en charge, quality of patient. Thank you for all the speakers, and thank you for MSD.